Yes, they can see it. They can see it. So what we are going to do today is just a presentation of part of the studies that we have undertaken in Nigeria on mental health, ban, stop, prevent. Okay, so it is titled Eradicating Harmful Practices in Mental Health Care by Changing Attitudes and Engaging Healers, Attitudes and Behavior. So I must tell you that this is a pilot study that we carried out in Nigeria, in Abia State, in Umuahia, in Abia State. And you'll see the details as we go on. First of all, I'm sure that not everyone here knows about, well, maybe those online. So make a quick presentation about us. I'm sure most of you here are online, you know who we are, but I will take a little bit of time to explain that as well. We are Magna Carta. So it's about NAS Magna Carta. NAS Magna Carta is a chapter of the National Association of Sea Dogs, Pirates, Confraternity, primarily based here in the UK, in the counties of Hertfordshire, Buckinghamshire, Bedfordshire, Huntingdonshire, and Cambridgeshire. And Northamptonshire. Yes, and Northamptonshire. Thank you. Yes, Shire. Yes. So what we do is we are involved in a lot of charity work, and within the last 6 years, we have raised over £20,000 in support of charities in the UK and also in Nigeria. But here, primarily, we have raised the 20,000 plus to support charities like Mind in the UK, Amudo UK, Prostate Cancer UK, and the driving support for mental health and healthcare causes. So we champion causes to make impactful causes, from mental health advocacies to human rights and women's empowerment, promoting positive and social change. We do a lot of volunteering as well. Majority of us who are doing this are not paid. It is voluntary. So if you look here on the picture there, you will see some old men with their pot bellies, but they managed to do 100 kilometers walk from, yes, in multiple times. So you can imagine that, just for the sake of humanity. So it's our passion. We believe that wherever a society needs a help, the pirate should be number one. So even if it means pain, bodily pain to us, we are like candles. We burn ourselves for others to see. So we do that. And then, I mean, we, clean up the environment just to make a difference while having fun. So you can tell that the men were having fun, although it was painful, but, fun. About Magna Carta, Work 347. From Magna Carta, so at some point, what we decided was to now establish Work 347. That was in 2019. It was conceived as SPV to collaborate with others of the same like minds who are passionate about advocacy and humanitarian efforts. So the goal is to effect positive change through fundraising, advocacy, direct community engagements, like what we have done here that I have mentioned. Work 347 collaborates with diverse organizations reflecting NAS Magna Carta dedication to creating lasting social impacts through mental health advocacy, human rights, and women's empowerment in the UK and beyond, like we will see. I mean, that's what this research is all about. This was carried out in Nigeria. We are here with some members in Nigeria in collaboration with them. So, but one of the things that someone here will ask, or someone online will ask, is why do we do that? Why do we do what we do, even with the pains? Even with the pains, we are still enjoying it and going ahead multiple times to do it. Like I mentioned, wherever the society needs help, we should be number one. We burn ourselves for others to see, just like the candle. That is in the forefront of what we do. So it's not just about fundraising, but also about reshaping attitudes and behaviors towards mental health. What we want to do is foster conversations amongst stakeholders like government, and then with the aim to influence government policies for better treatment access in mental health. So mental health advocacy since 2016, we've supported charities like mine in the UK, Amudo, UK, promoting mental health care and eliminating harmful and inhumane practices through initiatives like the BanStopPrevent project. We have an ambitious approach in which we strive to drive systemic change, ensuring compassionate, evidence-based care through collaboration, advocacy, and policy reform. As we go along, you will see parts of that, because we worked with the Commissioner for Health in Abia State, the Abia State Ministry of Health, the House Committee on Health. They're all involved in this project. So what we aim to achieve is that at the end of the day, we will help them to form a working document that not just for what we're doing now, but in the future, so that is what will guide the government policies in that. So passion for change, a passion for the Paris's humanistic ideal led to the funding of Work 347 in 2019, and inspired by the BanStopPrevent project in 2020, focused on mental health advocacy, both here in the UK and in Nigeria. So I'll give you an introduction plus a background to this very study that we have carried out. Our objective, when we started, we of course had objectives and aims, but the project goal, the BanStopPrevent Mental Health Advocacy Project, is a pilot study. It's a pilot study, like I mentioned, carried out in Nigeria, aimed at eliminating harmful and inhumane mental health treatment practices such as chaining, flogging, confinement to a particular area against their will, which is predominant in most Nigerian communities, in rural communities. Although it is rural, but we have had cases where even in town, state capitals, we have had, I saw one on TV in Kaduna State, in the capital, in the city, where people were chained in the name of treatment. So, this project, titled Eradicating Harmful Practices in Mental Health Care by Changing Attitudes and Engaging Healers. It has three stage processes. So what we did was to involve not just the healers, but the caregivers, the healers, the community, and everyone who is involved. So this is in three stages. The stage one is the research, which we have carried out, is a pilot phase. And then the second phase will be the advocacy. from this research, and we'll go back and look at the impact assessment, whether it was a waste of time, whether it has any positive or negative impact, but we have to check that. Yeah, the project aims to generate insights that can be scaled and adopted to other communities across Nigeria, contributing to a national strategy for safer mental health practices. So, like I mentioned earlier, if at the end of the day, Abia State government, for instance, when we present all that at the end of the research, and then they think, oh, wow, this is fantastic, let us replicate this elsewhere. Maybe other states will say, okay, what you did here, let's try it here. And what we're hoping is that at the end of the day, we don't know how long that will take, but at least we have started the process of helping the government formulate a strategy that will help in stopping these inhumane treatments. Okay, the field research objectives. The objectives of the field research is to gather insights into the local perceptions and practices related to mental health in rural communities. Specifically, it aims to understand communities' perception of mental health, identify prevalent harmful practices, assess the role of traditional and religious healers, explore potential advocacy interventions, and research findings for policy recommendations. This research phase lays the foundation for targeted advocacy and interventions to promote safer mental health practices. It is, when we just look at it like this, sometimes we may not understand it. But when you go to the field and you listen to people, what they say, some of you who are here, when we shared the updates, on daily updates, and then you hear what people say, please can we just, no, sit here. Sit here. No, that's fine, that's okay. So as we go on, you will see some of the reactions when we get the analysis of the results. You see some of the reactions of the people, how they reacted to this. So it's like trying to understand what they think it to be, what they know it to be, and their involvement. So for the scope of the project, what we did was in key data collection, the study engaged 302 participants. When we started, we were hoping and praying that we will get maybe 200, but as we continued, and then we were given, we employed men who went to the field, professionals who went to the field to gather this information, to do the interviews and administer the questionnaires. They were assisted by some locals, because one of the, as you see as we go down, one of the issues that we faced was the public acceptability. Some thought we were politicians in disguise, trying to come and increase the fuel price or the tax that they pay. So some were apprehensive at the initial stage, but as we continued with the help of the local guides, they helped a lot. So you can see the statistics there, the data that we collected. Community leaders, we interviewed 35. Community members, we interviewed 184. Patients and family caregivers, families/caregivers, 41, and the healers. Initially, we put all of them together, but at some point we thought it was wise to separate them. So we separated them. Now we have spiritual healers, 26, and traditional healers, 16. Like I mentioned earlier, the study was in 3 communities in Umahia, Apumiri, Barakuma, and Sukwe, located in Ubakala, Umahia South local government. These areas represent the mix of rural, semi-rural, and semi-urban setting where traditional healing practices are prevalent and often serves as the primary form of healthcare. As we go on, when we look at the data, the raw data that we got from the field, then you will see that mix. You see that mix. The project aims at generating insights, like I mentioned earlier, that can be scaled and adopted to other communities across Nigeria, contributing to a national strategy for mental health practices. So that's what we aim. And at the end of the day, the outcome of the research will now inform the decision of the government to have a working document, a strategy, so to say, that they, going forward, that's what they will use, not just in Abia, but across Nigeria. Yeah. And in collecting the data, what we did, we tried our best. We did the best we could to make sure that it was done professionally. If you look at the report, like you will see as we go on, some of the researchers are people who have, are tested and trusted in the field. Some of them have PhDs in research. So, but we deployed Kobo Toolbox and Kobo Collect. It's an app, yeah, but it's a very fantastic app for this kind of research because they were central to the data collection process, enabling real-time entry and secure data storage, even in areas where we have limited internet accessibility. What the Kobo app does is that it gives you the real-time location stamp and real-time stamp. So there's no hanky-panky about what we are doing. So even if that they decide we want to stay at home and just do anything, that will give you the timestamp, the exact time and the exact location. From wherever you are, you can just zoom in and see where they are at every point. So it was fantastic that we used that. I mean, even in places where, because in some places they will have, if they lose connection, internet connectivity, once they come anywhere where there is internet, automatically it uploads and puts the time and date stamp, the location stamp. So the survey included both structured and open-ended questions, allowing for comprehensive understanding of participants' perspectives. Some of the healers, what they did was, I mean, in the process of administering the survey, the questionnaire, sometimes they engage them just to see if they have a different perspective that were not captured in the questionnaire. Just make it a bit more interactive, and it was good because some of them opened up and then spoke to us about some of the things that probably were not captured in the questionnaire. We had some challenges, like I mentioned. Sometimes you lose internet connectivity, particularly in Sukwe. Occasionally hindered real-time data uploads. In some cases, the lack of geolocation data complicated verification processes. But like I mentioned, it wasn't like everyday occurrence. Just once in a while, We know it is common in Nigeria to lose internet sometimes. So, but the good thing is with the Kobo app, once there is internet at any point, automatically it uploads that. So you see the timestamp, you see the geolocation, the location stamp, and all that. So that helped in ensuring that the men did a very wonderful job. Okay, so still on the background and introduction, I'll give you a little of contextual impact. It is a very known fact that if you put the population of Nigeria with the number of psychiatrists that we have, it's nothing to write home about. In a population of 200 million, conservatively, we have roughly about 300 psychiatrists. And even with the 300, I can tell you that 300 are not on ground now. With the Japa syndrome and all that, I can tell you that you probably have less than 200. So it gives you the scale of the problems that we're dealing with. Yeah? Prevalence of harmful practices. Harmful mental health practices such as chaining, flogging, and containment. There are other ones, but we'll talk about that as we go on. Are prevalent due to misinformation and reliance on traditional and spiritual beliefs. This project aligns with international frameworks like the UN Convention on Rights of Persons with Disability, and also the World Health Organization guideline to advocate for human rights and dignified treatment for individuals with mental conditions. So sometimes even the healers, even some people in government, unfortunately, the people whose responsibility it is to formulate the policies, working documents, have no idea that it is a fundamental right for even the patients with mental health. They have for them it's, once you are, it's different here. When you came in, you saw the access to here, the disability access, but you don't get that in how many universities will you go to in Nigeria, for instance? So, because not that they don't want to do it, some of them don't even know that it is the right of the individuals who have mental health. Yeah? Okay. So let's not go too much into details because we have a lot to cover. So the project supports United Nations Sustainable Development Goals, SDG, particularly SDG 3 and SDG 10. And that is why we are doing it. So if you look here now, you see the time scale of the project. So first one is the field research. That's a pilot, which we have done. But like I said, we're not stopping here. We are also going to the second phase, which will be the advocacy. And even the advocacy, we have three stages of that. Stakeholders engagement and community outreach. So we're hoping to do that between October this month, end of this month, and November. And then after that, by December, between December and January, advocacy intervention design. And then between February and April of next year, we are looking at implementation of a pilot advocacy. And then sometime next year, May to July, look at the phase 3 of the project, which is impact evaluation, the impact of what we have done. So we are looking at this to serve as a template, like I mentioned earlier, that can be replicated across Nigeria. And then we have a timeline of August of next year to actually complete the project. Okay, on the research methodology, I mean, this is a teamwork. Let me not bore you with my voice. I think I will let my friend and colleague, is it on this one? Yes, okay. Yes, I'll let my friend and colleague, also my namesake, Chukudi, to give you a rundown of the raw data that we collected. Thank you.
Thank you very much, Dr. Chidinwigwe. And thank you for listening so far. And thank the people that are listening from Umuahia for their time. We're going to go into research methodology. Then we'll start with the research design. The original plan, as intended, was a combination of quantitative surveys and qualitative interviews for a comprehensive analysis of mental health perceptions and healer roles. He said, the previous speaker said, the data collection was done using Kobo Toolbox so that we could secure real-time data collection, ensuring accuracy and, for it to be both time-stamped and location-stamped. Adjustment due to funding and time constraints, the approach was changed to focus solely on quantitative surveys before the fieldwork began. But like I said, as we went along, adjustments happened as it should in this sort of situation. The duration and scope, it was conducted over 13 days in the 3 communities of Apum Mini, Mbarakoma, and Nsukwe, all in Umuahia South. The sampling strategy, we did a combined strategy of stratified and random sampling. We did this to ensure transparency and representativeness across key stakeholder groups. And then those groups in the stratified sampling were the traditional healers, who are of course involved in traditional medicine and healing practices, the spiritual healers, the religious figures performing healing rituals, the patients and the caregivers, and the community members. And random sampling, like I said, was applied within each stratum to reduce bias and ensure a diverse representation in the data collection process. The data collection tools and fieldwork strategy. We used different tools, including structured surveys, in-depth interviews, observation checklists, and of course the Kobo Toolbox that I mentioned, which ensured we got quality data and on real time. The fieldwork strategy, we had teams of 6 researchers that conducted 10 to 15 daily interviews. They were working in pairs. So we basically had 3 pairs, and they were supported by local leaders and youth guides, because of the issue of community engagement. And daily operations, the field research process were conducted, like I said, in Nsukwe, Mbarakoma, and Apum over 13 days, combining both quantitative and qualitative data collection through interviews with community members, healers, patients, and caregivers. In terms of engagement, strategy, and recruitment, build trust through local leaders and daily reports to refine the engagement, of course, facilitated by the local guides and leaders, supported, in so many cases by youth leaders. Adjustments were made to ensure sample diversity. We had field challenges because the researchers had to navigate difficult terrain, limited transportation and network issues with a mix of local solutions and traditional tools, which they engaged to surmount those challenges. We had debriefing sessions because one thing we knew was we had to, in as much as we were getting the data, we had to get the experiences so that we could adjust where it was needed. And we had this daily via Zoom between UK and Nigerian teams to review field challenges, insights, and actions for consistent data collection. And then we conducted this daily over 11 sessions, connecting the UK team with the team in Umuahia and Nigeria. Of course, we had ethical considerations in terms of adhering to international ethical standards. The research followed strict international ethical standards, ensuring informed consent, confidentiality, and participant protection in line with global frameworks. Participants were fully briefed on the study's process, purpose, and assured anonymity. Sensitive topics, including mental health, stigma, and harmful practices like chaining, were handled with cultural sensitivity. And the key ethical measures we had was voluntary participation. Participants had the right to withdraw at any time. Confidentiality, data was anonymized to safeguard privacy. Like I said, they were collecting it real time and it was just going straight to the bank that we had and without any access from anyone. Cultural sensitivity, local customs and traditions were respected, ensuring culturally appropriate engagement. We had limitations, of course, like you would have in this sort of study, which was a pilot. But it yielded some important insights into mental health practices. So some of those limitations were focus imbalance, because greater emphasis on chaining with less focus on torture and destitution. Of course, in future research, we will correct this imbalance. Access to modern care, lack of questions assessing whether participants knew how and where to access modern mental health facilities within the local government area, which limited insight into the awareness of available healthcare options. Mixed method constraints, initially designed as a mixed method study, but was reduced to quantitative only due to time and funding constraints, limiting qualitative insights. We had other limitations like sample representation due to logistics challenges. Certain parts of the villages may not have been fully reached. Some questions, we got to find out were a bit complex. Some participants found the Likert scales challenging, both in comprehension and in how they were displayed on the mobile device used by the field researchers. Simplified responses improved data clarity and usability. Number of questions. Early feedback raised concerns about survey length, although these issues lessened. Question volume may still have affected engagement and response quality. Network failures delayed data uploads, as would be expected from that terrain. Paired validation helped to confirm geographic accuracy. Bias and compensation. Some participants expected compensation, but like I mentioned earlier, our ethical guidelines on non-compensation were followed to prevent any bias, because we didn't want to seem to, act like we're inducing anyone. Technological issues, network failures, delayed data uploads, paired validation, again, help to confirm geographical accuracy. So when we had the Kobo toolbox, sometimes the network wouldn't allow it, but because they were working in pairs, one person who could use that person's location to, pinpoint the others. Cultural beliefs around mental health influence response openness. Local guides helped, but stigma likely affected response depth. So at this point, I would call on Mr. Chiemeko Zumba to take us through the preliminary findings. Thank you.
Hello, everyone. So, needs to be the height for a pastor. Well, thank you very much. So we're just going to go through the preliminary findings. The analysis work is continuing. They are quite already very interesting key findings that we've picked up that we can share straight away. I'll go through the data analysis, and it's up on the screen so we can see that. So where it says 4.1, that's the question that was asked. Then we can see what the breakdown of the responses were. So with this question, it's how do you believe mental health conditions should be treated. And we can see that the majority of the people talk about a combination of traditional, modern, and spiritual methods. This question was about how effective do you think traditional healing methods, herbs and incantations, for example, are in treating mental health issues. You can see as well that there's quite a preponderance of believing that they are also effective. How effective do you think spiritual healing methods? So we had to ask separate questions for spiritual and separate questions for traditional, and you can see what that is as well. So almost similar kind of numbers for belief in the traditional as well as the spiritual. Have you or someone in your family ever sought treatment from a spiritual healer for mental health issues? Majority of that was no. Part of the analysis we're digging into is to find out whether issues around stigma has influence in this data. So there's quite a whole lot of nuances in all the data, and that's why this has to be a preliminary finding that we're looking at currently. Do you think mental health conditions should be treated with modern medical treatment? Overwhelming 82% says yes. How open are you to adopting modern medical treatments for mental health conditions? Overwhelming percentage also are very open to this. Do you believe there are benefits to combining traditional, spiritual, and modern healthcare methods for mental health treatment? Overwhelming majority think yes, there should be that combination. And I think this question is one of the questions that is at the heart of what we're looking at, because at the conference in 2020, if we recall, that idea about is it possible to engage with healers as a key strategy to helping to deal with those with the issues of harmful practices involved in mental health treatment. So it's always interesting that the data seems to show that almost the same number of people who say, yes, we should use modern methods matter, including the healers themselves, also think, yeah, we can combine all of them. Also think, yes, the spiritual works. Also think, yes, the traditional things work. So there's so much analysis to really understand what the data is telling us. Do you believe there are safer and more effective alternatives to outdated or harmful practices such as chaining, flogging, or seclusion for mental health treatment? For women, 86% says yes. So that is positive. That is quite, it indicates. And even when that same question was put to healers, an overwhelming number of them also think yes, they think there are safer and better alternatives. So with this question, we are looking like, because a key part of the strategy for this research is to identify effective advocacy that is linked to the communities. So it's not just enough, probably we want to apply something that happens in Lagos or solutions that work in Lagos to apply it in, for example, Barakoma. So we're then asking top 3 ways to encourage traditional and spiritual healers to adopt safer and more effective practices. And the group in blue up there, which is 49%, indicate more people think a combination of education and training on modern mental health practices, collaboration with healthcare professionals, and community awareness campaigns can make that difference. So, what are the most significant barriers preventing people from seeking modern mental health treatment in your community? Select the top 3. So this is about access to healthcare. And of course, number 1, cost of treatment. And you can see in all those 3 groups, cost of treatment was number 1 in that. For the 51%, stigma around mental health, lack of education or awareness. It's also interesting that stigma around mental health appears one more point down, and limited access to services is also there on 2 points. Sorry. Do you believe that spiritual or cultural beliefs influence people's decisions to seek modern mental health treatment? And an overwhelming 72% say yes, they prevent people from seeking those treatment. And there are also a lot of research that's happened already, which indicates this, and this is actually at the heart of what this project is about. How can we understand this and help community by community to find the right strategy to help change attitudes around this? How important do you think the role of traditional and spiritual healers is in shaping attitudes towards mental health treatment in your community? A overwhelming number of people think that it's important as well as very important. And that seems to echo what Work 347 and NAS Magna Carta as far back as 2020 has thought about, that potentially the traditional healers and the spiritual healers being right there, being even closer, and people have more access to them than the modern medicine, could be right at the heart of a strategy to help change attitudes and change the use of these harmful practices. Do you think traditional and spiritual healers should be trained in modern mental health care practices to better integrate both approaches? An overwhelming percentage of people say yes. But we think collaboration is a key thing. We can't continue to say, no, we're going to deal with them. They are the issues. Probably we now need to move beyond that and be able to sort this out. And one interesting thing is that through the observational tools that the researchers deployed, we also realized that both spiritual healers and traditional healers, at least in these communities, are actually also using modern medicine. Because one of the feedbacks from one of them was one of the challenges that are facing is actually assessing original psychiatric drugs. So we are seated here and thinking spiritual healers and traditional healers only use the tools we think they use, but actually it seems a good number of them actually using the modern medicine in their healing practices. Do you think traditional and spiritual healers should be part of the solution to improving mental health care? Overwhelming 84% says yes. Would you support a community program aimed at educating people about mental health and treatment education information? 96% yes. Do you believe mental health conditions should be treated with traditional methods, modern medicine, spiritual healing methods, or a combination of these? This is quite an interesting one, because this is now a question put to the healers themselves. And you can see that the overwhelming majority of them think that a combination of the practices they are using as spiritualists or as spiritual healers, the practices they are using or the tools they are using as traditional healers should be combined with modern medicine. Would you consider safer and more effective alternatives to current methods such as chaining, flogging, or seclusion for mental health treatment? Now, this is a question to healers themselves, and overwhelmingly 73% says yes. And part of the analysis we're doing is also to dig into this yes, to understand it more. Is it a yes on the basis of, well, I don't know who I'm speaking with, I'm just going to go with the best response. But actually, while in the field, it was interesting that the field researchers came across, and it was just one case of someone who was actually chained. And I think a report on that is already on the Work 347 website. But anecdotal evidence indicated that in all the, apart from this one instance, all the other healers that they interviewed, there was no observed use of any of these harmful practices. Do you think spiritual or cultural beliefs prevent people from seeking modern mental health treatment? Overwhelming 55% say yes, they think so. Now, is it mainly because of the beliefs, or is it also because of not having access to modern medicine? This is all part of what our analysis needs to dig into, because if the healers themselves are saying they're using modern medicine in the healing, you're then wondering how come then the patients themselves think that it will be the traditional and the spiritual that is most effective. But a lot of these data seems to indicate, and we will only be sure when we conclude the analysis, seems to indicate that there is something in the idea, the hypothesis that Work 347 is working with, which is that the collaboration with healers will be a good strategy towards changing attitudes and dealing with these harmful practices. So that is for the findings. I'm just going to run through the demographic analysis, and I'm sorry if I seem to do that a little bit faster, just so that we can have enough time towards the end to talk about next steps, as well as to have the conversation, which is important from questions and conversations on this. So on the demographic analysis, participant groups like Mr. Onwudinati talked about the strategies around methodology. So there was community leaders as a group, community members, patients and caregivers and their families, and spiritual healers and traditional healers. We did have a target for each of these groups, okay, and only the one that put together the spiritual and the traditional healers, we put them together as a group of healers. We did meet that target of the number of people we wanted to interview, but if we then split it, we didn't meet that target. But for all the other groups, we did meet the target that the research was planned and designed on. So that's the age distribution as well. And within the age distribution, when the full report is out, we will actually compare this to the 2006 census, what it says about the population of Umuahia South. We're not able to get the population figures of the communities because the National Population Commission will only release up to local government level. But the age distribution seems to indicate that it reflects the national population census. The gender as well, the female is slightly over the male, and that reflects what the population census for Umuahia South indicates as well. Education, you can see what the breakdown of that is, from higher education all the way to vocational and technical, as well as people who didn't have education as well, formal education. Occupation subgroup. So this was quite an interesting one. This was the only demographic questions where we used free text. And we used free text because we wanted to be able to capture as much as possible the full mix of what people say they do for occupation. However, we then had problems at the point of analysis because the cleaning up the data, for example, someone would say, I'm a barber, another person says, I cut hair, you know, they're the same. But so all that, what we then did was to go with the NBS, the Nigerian Statistical Organization. So we went with their own breakdown of occupation groups. So we got breakdown of occupation groups, but we found that to be too high level for the range of occupations we had. So we then had to go with the occupation subgroup to make the comparison. Location, Mbarakuma had the most highest respondents, and that reflects on size. On the size, what we think the size of the community is. The field researchers tried so much when we couldn't get data from the population agency on the communities. They tried so much to see if they could gather that from the community, but that was also difficult. From anecdotal evidence, and Barakuma is the largest of those communities, and that also reflects in that we had more interviews there. Religion, of course, the highest number was Christianity, reflects what's on ground, but it was interesting to interview a number of people of the Muslim faith, and as well as one person from Judaism, and a good number of traditional and indigenous religion adherents. So our analysis is ongoing, but the key part of it that we can talk about now with regards to community attitudes and the role of healers. So adoption of modern treatment. 70% of respondents are open to adopting modern treatments. And 82% support treating mental health with modern medicine. However, 79 and 89% still believe in the efficacy of traditional and spiritual healing, respectively, indicating that traditional methods and spiritual methods seem to hold significant weight. And that's part of what we are hoping that with the deeper analysis we're running, we may be able to understand what exactly is happening with, is it possible to, on the same level, believe in modern medicine, believe in the spiritual way, and also believe in the traditional way. If it's that way, that's great. But the key thing that is clear is that there's preponderance of preference for combination of treatment methods, because 75% believe in combining traditional, spiritual, and modern methods of mental health, with preferences varying for combinations of different approaches. With regards to the prevalence of harmful practices, that the awareness of it, 86% recognize safer alternatives exist to practices like chaining, flogging, and seclusion. And like I said, it was interesting that for our field researchers, apart from that one instance, they didn't actually come across the usage of these harmful practices. Now, we don't know why it wasn't so. But one key thing interesting is that that one case that they came across, someone who was chained, did not have to do with their treatment. It had to do with payment. And that also then points towards that the cost of testing healthcare medication, which also seems to be high on even assessing spiritual and traditional healthcare for mental health conditions. Role of traditional and religious healers, which is also key to what we're doing, key to the project. Influence on mental health attitudes. 77% believe healers shape community mental health attitudes, and 84% think they should be part of the solution to improving care. Yeah. Hopefully we can get to the bottom of that. Training of healers. 76% of respondents support training healers in modern healthcare to bridge traditional and modern practices. And we are thinking at this stage that if these healers are already using this modern medicine, we might as well be looking at actually training them so that we are sure that, you know, they are meeting the very the rigor and the standards for use of modern medicine. So I'm going to now hand back to Mr. Nwudinanti, who is the head of the project, and he's going to talk about advocacy recommendations, as well as what the next steps are for this project. Thank you very much.
Thank you very much, Mr. Zumba. And I would advise at this point, you know, we've got refreshments to keep themselves fresh. And then we thank you for people online and people at the Maya Center for staying on. Right. So we go to the advocacy recommendations, because this is the crux of what we're trying to do. Now, the reason we went into this study in the first place was just like the Mr. Zuba said, was we didn't want to base whatever we were going to do on anecdotal evidence or what we thought. We wanted to see what exactly was happening, to have the data. So the data suggests that a multifaceted approach would be most effective. Key methods identified by 49% of respondents include education and training on modern mental health practices, collaboration with healthcare professionals, and community awareness campaigns. These interventions are seen as crucial for changing the attitudes of traditional and spiritual healers and encouraging them to adopt safer, evidence-based practices. Now, there are barriers to modern treatment. The most significant barriers preventing individuals from seeking modern mental health treatment were identified as the cost of treatment, stigma around mental health, and the lack of educational awareness. With 51% of respondents highlighting these factors, addressing these barriers is essential for improving access to care. Like Chiamaka said, one of the one thing we found which involved training didn't really have to do with the training, with the treatment. It had to do more with the cost of, assessing that treatment. And policy recommendations to overcome these barriers, several key policy interventions are indeed necessary. Subsidizing treatment costs. Ensuring mental health services are affordable will encourage more community members to seek care. Because if they don't seek care, then they're not going to get the care. Anti-stigma campaigns. Public awareness campaigns aimed at reducing the stigma around mental health conditions would make it easier for individuals to seek treatment without fear or judgment. Expanding community mental health services. Increasing the availability of local mental health services, especially in rural and semi-rural areas, will improve access and provide individuals with alternatives to traditional healing methods. These advocacy and policy interventions must be implemented as a comprehensive strategy to reshape mental health treatment practices, support healers in adopting safer methods, and reduce harmful practices like chaining and flogging. And that will take us to the next steps, which, like I said, is the crux of what we are trying to do here. Now, for the immediate next steps, as we have highlighted already, the analysis is still ongoing, and we're going to present a comprehensive report. And then the action will be to conduct, like I said, a full analysis of these pilot findings. The purpose will be to finalize a report for stakeholders, highlighting key insights and limitations. And that we're going to do immediately. Next step will be refining the questionnaire. Like, we pointed out in our presentation earlier, because it's a pilot scheme, because it's the first time we're doing it, we found that there were things we had to change, and the lessons have been learned. So we'll address the gaps in the questionnaire, example, to focus on torture and access to modern care, improve question design for clarity and better data collection in future phases, with the purpose, and we're going to do that immediately. Another step will be to community and stakeholder feedback. One thing we ensured that we did in this research was to engage the community. We started with the community leaders, who I'm sure some of them are my head there, the traditional leaders from the 3 communities, the youth leaders from the 3 communities, and other community members, which some of them are there now. And then the action will be present the findings to the community leaders, the healers, and the policymakers. And in terms of the policymakers, we know that the chairman of the Abia State House of Assembly Committee on Health is there. Maya is at the Skills Center, so he's listening, to what we're saying. And then the purpose will be to gather feedback, to refine interventions, and ensure alignment with community expectations. Because one thing we told the researchers from the beginning was, we're not coming to condemn completely, but to work collaboratively to make sure we got better outcomes. And we're going to do that immediately. These steps are critical to undertake immediately after the pilot research. We validate findings to ensure the data collected is thoroughly analyzed and accurately reported. Because like I said, this is the pilot. We intend to use this as a template to widen the research. Because from what we've learned, cultural differences would definitely have some impacts on whatever the findings would be. Because we know we have a very large country with different people and very diverse cultures. We would improve our research tools to refine the questionnaire and methodology based on pilot insights, like I said. And we engage stakeholders. We engage stakeholders and then obtain valuable feedback from the community to refine strategies and foster collaborative relationships. We have our strategic roadmap because, like I said, like we all know, if you don't, if you fail to plan, you're definitely planning to fail. So we're going to scale. The next step will be to scaling advocacy initiatives, in the sense that we'll plan broader advocacy efforts, including education and anti-stigma campaigns. The purpose will be to expand reach and encourage adoption of safer mental health practices. We're going to do that in the medium term. And then we'll do a future research, further research and expansion. Like I said, we intend to widen our scope, widen the geographical area, because we know that there'll be cultural differences and that would impact on what we're doing. So we'll implement a refined model in other communities starting in August 2025. We integrate modern mental health care practices with traditional methods to ensure safer care. Like I said, that will be in the medium term. We'll intend to train the healers to develop and implement training programs for traditional and spiritual healers, working with some partnerships we're already forming with some organizations like Amudo UK, Amudo Integrated Community Health Nigeria, who their representatives are online listening. We'll gather feedback to refine interventions and ensure alignment with community expectations. This we will do in the medium term. And then collaborating with authorities. That's one of the reasons we're happy we got very good reception and very good cooperation with the local government chairman of Umuahia South. We got very good cooperation with the community leaders. We got very good cooperation from the Ministry of Health. And we got very good cooperation from the members of the Abia State House Committee on Health, who are all represented. So we engage with local and national health authorities to advocate for improved mental health services. We work to secure funding, support, and policy changes for broader access to mental health services. Indeed, when we're discussing with some of the organizations that are involved in this, we told them that you are the experts who want to provide a voice. And we want to use the networks that we have, the networks that we developed over the years, the broad spectrum of skill sets that we have to lend a voice to what you already do, so that we could see how it could be done better. This we'll do in the medium term as well. And then we'll do continuous monitoring to establish a system for ongoing monitoring and evaluation of advocacy interventions, so that we'll be able to measure, ensure measurable impact and continuous improvement of mental health services. That we will do in the long term. And now I will call on Dr. Chidimigwe to come and take us through the conclusion. Thank you.
Thank you, ladies and gentlemen. Thank you once more. So just to go through the concluding part of the presentation. Our daily operations, the BanStopPrevent pilot research has provided essential insights into community perceptions of mental health, which is what we set out in the first place to do. The role of traditional and spiritual healers, and the barriers to modern treatment adoption, like Chemika mentioned. And then also the barriers to adopting modern traditional treatment methods. While the research focused faced some limitations, like we mentioned here earlier, it offers a valuable foundation for scaling advocacy, refining interventions, and implementing policy changes. As we move forward, these findings will shape our next phases, expanding our work to the communities and continuing to advocacy for safer, evidence-based mental health practices. The lessons learned from this pilot will guide our efforts to drive lasting change. So it's not just to do the research and keep the paper somewhere. It's just to ensure that whatever lessons that we have learned here can be replicated in other communities across Nigeria, not just in Abia, but across Nigeria. And then also what we want to see is that at the end of the day, people with mental health challenges are not treated differently or inhumanely because of their condition. We have lots of people involved in this project. If I start reading the names, I think if you look at the screen, you can see we have lots of people, lots of partners, but it is a Magna Carta project, I must mention. It is not one person. There's no person on board Magna Carta that is not involved in this project. They have contributed in one way or the other. Yeah, even those who are not in Magna Carta, if you look at the list, you see a whole lot of them. You go to Abia, House of Assembly members, House Committee on House Committee on Health. They've been so helpful. People from that are not even from here, from different zones, different decks. Mr. Kelemo and co, a whole lot of people. They've all contributed in one way or the other in this project. So if we start to mention the names, I don't know if you want me to go on mentioning the names, but you know, a lot of them, a lot. Like I said, I don't know, I cannot think of any person in Makata. Not just the people, also the family. So in some cases, it's a family. Wives are involved, the children, they are grown, they are involved, and in one way or the other. So I must say a big thank you to all of you. Yeah. So in that case, this is officially the end of the presentation. I would like to say a very big thank you to all of you, just for those who are here physically, for those who are online, for those who are in Omar here physically. There's one particular woman, I don't know if she's still there, but she promised that she was going to come, that she must come. The mother of the lady, the young girl that was unchained, she was overwhelmed with joy and said that she must come. So I'll ask the team